Thank you for the invitation to talk to you today about managing the parastomal hernia recurrence. These are my disclosures. It's 2 years ago now since I was invited to give a talk at Sages about my worst complications in hernia surgery. And at that time, I was of the view that the best summary of complications from hernia surgery were in The House of God by Samuel Shem, particularly Law 8, that they can always hurt you more. And I think on reflection, I've come to the conclusion that it's parastomal hernia surgery that is perhaps the most challenging in all of hernia surgery. And it's challenging both for the surgeon and for the patient. And the great thing about this condition is that you're never alone in your pain, because even when you think you're an expert and you know what to do, you still sometimes have to phone a friend. And the people I phone to ask, what do I do about a case, share cases with me about their own challenges, like this case that Philip very kindly shared with me about a patient who'd had watchful waiting following the formation of their end colostomy, ended up presenting as an emergency, required major laparotomy, very quickly recurred, represented with obstruction again, needed further surgery, and so on. You get the picture. It is an unforgiving condition. And really, parastomal hernia repair is no walk in the park for the patient. And although this data relates to primary repair, it's really quite sobering. You can see that the increase in the number of repairs done over time as people have decided to take these cases on. But interestingly, look at both the morbidity and the mortality that comes with parastomal hernia repair. Mortality in particular is at the same level as the mortality associated with the index surgery to give the patient their stoma. Now, you might argue that this data is somewhat out of date, dating back into the 1990s, for example. However, look at the recent data that's come out of Copenhagen, published in Surgical Endoscopy this year. With laparoscopic surgery approaches, the rates of complications are still high, 25%. Rates of reintervention, similarly high, 25%, and even more patients get readmission. The post-operative pain, whether at rest or during activity, is still high, and the patients report fatigue for several days afterwards. It's not simple, straightforward surgery. Indeed, any of you on social media may well be aware of some of the patient microblogs that are available, and this is from the Association of Coloproctology Patient Liaison Group member Sue Blackwell, who's highlighted in very great detail and quite movingly about the complications that she's had from her 6 parastomal hernia repairs over time, including relocation. It really is quite sobering to see what patients go through and the poor rates of success. And it's because of this that the patient who has a recurrent parastomal hernia has a real dilemma, and we share that dilemma with them. All of these questions the patient is asking, and so are we. And the challenge is we so frequently have answers that are evidence-based or have sufficient experience of our own to say what our outcomes are for this particularly unique group of patients. What we can say is that parastomal hernia has an impact on quality of life. So when patients get a recurrence, you know it's likely to affect them. And this excellent study that came from the Copenhagen group and was published in Annals of Surgery towards the end of last year details very nicely what happens to different groups of patients with their quality of life. Put simply, if you have a bulge next to your stoma, your quality of life is reduced. If you had your stoma for benign disease, your quality of life is affected more so than if you had your stoma for cancer. If you have an ileostomy, your quality of life is reduced more than if you have a colostomy if you get a parastomal bulge. And if your bulge is particularly large, then your quality of life is reduced even further. So just how common are recurrent repairs? Well, again, the same Copenhagen-based research group did data linkage studies between several of the Danish registries that exist, both those of the national patient registries looking at what happened in terms of hernia repairs and the stoma registry that they have. And you can see from time of diagnosis of the parastomal bulge, the number of attempts at repairs accumulating over time. Now, of course, many of the patients will have had the stomas formed due to cancer, so you can see the competing risk that death from other causes has. But when a patient has had at least one parastomal hernia repair, you can see over time the aggregation of further attempts, 2 or more repairs. And by 5 years after the index diagnosis of a parastomal bulge, you can see that up to 1/3 of patients have had 2 or more attempts at repair of their parastomal bulge. So what options are taken in these circumstances? It's worth bearing in mind that Denmark has centralized parastomal hernia repair to 5 centers. And yet we can see in their database linkage study the absolute myriad array of options that have been taken. The primary repair, the first recurrence, the second recurrence, and even the third. No clear standardized pattern or approach taken, all depending, of course, upon whether the patient presented with an emergency or an elective situation, the type of stoma that they had, and so on. So what are the management options that are out there? Well, as with primary parastomal hernias, the commonest strategy is watchful waiting. The difficulty is we don't know what its risks versus benefits are. We don't know whether just leaving it alone means that the stoma gets larger over time and then becomes more complex and difficult to fix. And we certainly haven't got a handle on, for patients with recurrence, what are the indications to operate when we're looking at quality of life being disrupted as the main impact of the stoma. Now, of course, if they strangulate or if they obstruct, your hand might be forced. But what symptomatology is unclear. There's only one real paper out there which details in any great extent the watchful waiting approach, and that came from 2 centers in the Netherlands and was published in colorectal disease a few years ago now. Patients who underwent watchful waiting tended to be older with more medical comorbidity, were more likely to have had the stoma form of cancer and tended to have fewer symptoms. But nevertheless, the crossover rate was still 1 in 5. And you can see that when the patients did come to surgical intervention, that the morbidity rates were high and the subsequent recurrence rates were similarly high, highlighting the futility of operating on this group of patients. The issue is, when you consider the population of the urban area served by the hospitals involved, it was clear that the number of cases that was in the paper was somewhat lower than you'd expect. There'd been some degree of selection bias, and perhaps to the extent of a whole order of magnitude, given what we know about the epidemiology of parastomal hernias. So the reality might well be this, that the oligosymptomatic patients are hidden from us. They probably are out in the community, with their primary care physician, or with our stoma care nurse colleagues. And that when we see polysymptomatic patients, at best we're seeing the very tip of the iceberg. And what's really happening is that most patients just get on with their life and carry on with their everyday activities, using things like support garments such as these to help them cope with their parastomal hernias. And it really does come down to expert stoma care nursing and the provision of high quality care. And I'm very fortunate to work with an outstanding team who have been instrumental in helping me provide the service in Exeter. So how do we approach these patients? Well, we always see them together, stoma nurse and I, and the patients tend to go through the same pro forma as we would do for our primary repair patients. We survey the patient and the problem, talk about the pros and cons of surgery in detail, consider our operative and measure options, and think about how we're going to care for the patient post-operatively with different stoma appliances and adjuncts such as support garments. The most important thing really, I think, is to make sure you've got an up-to-date CT scan so that you can look at the actual defect and whether there are any concomitant incisional hernias. The EHS classification is probably the best of an unvalidated bunch of classification systems. Many of the patients have comorbidity and they've been through an awful lot. They're often not in the fittest of health. Many are smokers and obese and need to be optimized. And the same approaches are taken for these patients as they are for incisional hernias and for primary parastomal hernias, that they have to be optimized. You need a multidisciplinary team to optimize them, and again, the same mnemonic stoma applies with all the different professionals who are required in order to optimize your patient and rehabilitate them prior to definitive surgery. The approach we take really is a tailored one. I have to say, overall, I've tended towards open surgery for those who are having recurrent hernias, often because the laparoscopic approaches have been used for the primary repair. In essence, those patients who've got large parastomal hernias, notably class 3 and class 4 in the European Hernia Society classification, tend to have open surgery, particularly if they've had previous open surgery, index surgery to give them their stoma, they tend to get open repairs, and if they're going to have anything else done at the same time, open surgery I tend to favour. Laparoscopic surgery really comes into its own for those who've had laparoscopic surgery to form the stoma a priori, and if they've got small parastomal hernias, or if they've got their first repair was either an onlay approach or just a sutured approach if it was done as an emergency. It really is a case of apples versus oranges. In my mind's eye, this is what the patients look like in the different approaches, and the CT scan similarly. On the left, one that will approach with open surgery, and on the right, one that will probably adopt a laparoscopic approach for most likely a laparoscopic sugar baker. The one thing I don't do is I don't try and relocate the stoma. I think multiply fenestrating a patient's abdominal wall really leads to a resounding success for the patient. And all you end up doing is having an incisional hernia at the old stoma site, an incisional hernia in the midline laparotomy, and a new parastomal hernia at the new stoma location. It really isn't advised and is recommended against doing it by the ACP-GBI guidelines. The other thing I try to avoid is doing onlay repairs as much as possible. We did look at this about 10 years ago, and all of the patients who we fixed using that technique all got recurrence. It really doesn't work. I try and avoid it at all costs, except in extremis. So what do we do? Well, this is our data published earlier this year. Rhiannon Harris, our fellow, collated all the data together, and there was a decade's worth of experience from 2010 to 2019, looking at all of the patients we had with at least one recurrent parastomal hernia repair. We had quite a range of patients with different comorbidities, many of them ASA 2 and 3. The indications for the stoma, a whole range of different things between colorectal cancers, other types of pelvic malignancies, IBD and functional disorders, with a whole range of different stoma types. The primary parastomal hernia repair that have been done, often in other hospitals, documented in the middle table with a whole different range of things out there. You can see that the high prevalence of biologic mesh use indicates the fashions at the times. And you can see what we did in table 3 in the 38 patients and 59 repairs that were undertaken. There's lots of different approaches using different mesh types. Still, half of the patients have biologic repair. More recently, we've tended to go for synthetic or biosynthetic options, noticing no benefit for a lot of occasions with the biologic meshes. And you can see overall that it doesn't really matter whether you look on a per patient basis or on a per hernia basis. The recurrence rate, again for recurrent parastomal hernia repair, remains very high, with over half of patients at 5 years having a recurrent parastomal hernia. It matters how many times you've had an attempt at repairing the hernia. If it's your first recurrence, you're more likely to do better than if it's a multiply recurrent parastomal hernia, who do very badly indeed, even by 12 months. One thing it is worth noting is that we did look at the number of recurrences that we had and compared them to the classification of parastomal hernias at the beginning. It seems that multiple attempts at repair doesn't seem to worsen the EHS classification of the parastomal hernia back. And you might wonder about why are surgeons with an interest in hernia and abdominal wall surgery looking at all these different options, and why is there such variation? Well, it's because it wasn't just the two of us in the unit who do have a dedicated interest in complex abdominal wall reconstruction of parastomal hernias. There were 6 surgeons across the board who ended up operating on such patients with widely varying numbers. It's clear that we don't have high quality evidence about what to do for these patients. And in part as a response to this, the European Society of Coloproctology and the Ileostomy Association from the United Kingdom have funded a new study to look at what happens to patients undergoing parastomal hernia repair, both primary and recurrent. And the PROFA study was due to launch in March or April of this year, but has been postponed due to COVID. It should be open by the end of the year. It's not just restricted to European centres. All centres around the globe are welcome to join. Please do look at the details on the ESCP website and sign up if you wish to join us. Try and get the answers to the conundrum that this unique condition poses. So in summary, recurrent parastomal hernias are common. Approximately 1 in 3 patients who have a parastomal hernia repair will need at least one further repair. The first attempt at repair for recurrence is likely to be your best chance, and multiply recurrent hernias are unlikely to be readily amenable to definitive repair, and further recurrence is likely. It truly is the Sisyphean challenge. Non-operative strategies may be in the patient's best interest, given the morbidity and mortality of surgical repair in those who are multiply recurrent. Thank you for your attention.